Welcome to Own Your Heart Health. I'm Dr. Regina Druz, your holistic cardiologist. This week, we will dive into common heart health concerns, uncovering root causes, and unpacking scientific discoveries and controversies. The information provided does not constitute medical advice. Please contact your healthcare practitioner before making any changes that may impact your health. Welcome, everybody. I am very excited today. This is an episode that is being recorded literally a day before Valentine's Day. And, here I am with my wonderful guest, Dr. Ellie Campbell, who is all heart. She is a great mentor, a great friend, and a really top-notch primary care functional medicine doctor who is focused on cardiometabolic health and all things that have to do with health and longevity in general. Dr. Ellie, welcome to the show.
Thank you so much. It's my honor to be here. And we chose Valentine's Day to do this recording because cardiovascular disease is the number one killer in our country of men and women, and it doesn't have to be. We can take it off the list if we are willing to get the tests and do the work. And so I think that it is enlightening to patients to know that they have power and that with the right coaching and the right guidance that they can make a huge difference in their blood pressure and their cardiometabolic health and then their risk for heart attack and stroke.
100%. And I think this is so important for everyone who is listening to us to realize that sometimes I see patients or just us adults, right? We want to find a magic bullet. We want to find this magical solution, a magical wand, but there really isn't a magic wand. Everything that your body is capable of, you can unlock. You just have to have a right person to help you follow the right steps for that unlocking to happen. And so in your example, right, you recently released a book on hypertension. Here it is. It's called The Blood Pressure Blueprint, which I read, quickly. I have to admit, I have to be honest, but
it's
I do
like a hard read. It's an easy read. It's a
easy read.
Kind of a boring subject, but I don't think it's a boring book.
And not at all. It's very practical. So I actually did enjoy reading it. It sort of doesn't have a lot of the extra, more complicated things that people sometimes find in the hypertension books, but I think it's very practical. It's very sort of user-friendly. So Ellie, considering that you are in the primary care functional medicine space, why hypertension? Tell me, how did you come to choose this topic? Why this topic? What are sort of the paths of development in this?
Yeah. Well, it's kind of a funny story, actually. I think the book is a Trojan horse. A Trojan horse.
Yes.
In ancient Greece, Helen of Troy sent a horse to her opponents as a gift, and they gladly accepted the gift, not knowing that there were soldiers hiding inside of it that took over the city and won the battle. So what was disguised as a gift actually had really important things inside. And that's what my book is. My book is really a book about everything that every functional medicine doctor talks about, which is the fundamentals of wellness. Eat clean food and drink clean water and exercise and pray and meditate and spend time in nature and get good sleep and have a purpose in your life. And those are fundamentals for everyone. But it's a really boring book. Nobody wanted to read it.
Yeah, because people didn't find the magical solution, right?
Right.
You could have said, let's sprinkle some magnesium or let's sprinkle some omega-3 fatty acids and add a little glutathione and poof, your hypertension will magically disappear. But right. As Dr. Ellie tells us, no, and no, right? So it's all about work. So
hypertension work. And also, I'll tell you the story of Dee because it really is what brought me to this book. So I'm a primary care family medicine doctor. I've been doing this job for almost 35 years. I've got a lot of experience. And for a while, one of my specialties was helping infertile women conceive. Did a lot of work, mostly on thyroid, adrenals, and progesterone, detoxifying their life. And we got a lot of ladies pregnant. There were about 100 babies born that were supposedly infertile. So that was a wonderful part of my career, and I was really happy. And Cheryl came to see me at the age of 42, wanting to have a baby, having failed fertility clinic because they said her egg and her husband's sperm were incompatible and they
Wow.
could not have a child. And she said, but we already have one son. So I don't think your calculations are
Is
correct. I'm
correct.
going to
Yeah.
go see this friend of mine says she's got a friend that had a baby from Dr. Campbell. So maybe we can try. So we got Cheryl pregnant, and she had a child at the age of 42, another second son, and everything was marvelous. And she said, boy, Dr. Campbell, you're really good with hormones. I think my mother needs to see you. So
Okay.
as a family practice doctor, that's like thrilling to me right now. I have the child, the mother, and the grandmother, the whole
You
family,
have three generations.
three
Yes. All
generations
three
in my care.
generations in there.
And that's just a blessing to be on that journey with that whole family throughout their life cycles. And so I started seeing the grandmother, and she had high blood pressure, which we treated conventionally and followed the best evidence-based guidelines. She had high cholesterol. We treated that, and we put her on bioidentical hormone therapy, which changed her life because she was young and vibrant and spunky, and she liked to four-wheel with the grandkids, and like she was in the bookkeeper to the family business. And then
Mm-hmm.
one
Mm-hmm.
day, her daughter called me, panicked, and said, Mother did not come in for work today. She drove over to her house. She looked in every door, every window. She found her mother crumpled on the floor,
Wow.
conscious, barely breathing, paralyzed on one side of her body. She'd had a massive stroke. They brought her to the stroke center, undetermined length of time. She wasn't a candidate for the magical stroke clot
Yes,
busting
for the
drugs.
clot busters. Yep.
The timing was too long. So she had to go to the stroke rehab hospital across the street. And she joked with me it was going to take a lot of physical therapy rehab to get that dragging leg fixed so she could go line dancing again. And then, about day 4 of her hospitalization, she developed this tragic complication called hemorrhagic transformation. And
Oh,
what that is where the blood vessel that was damaged by the stroke burst open. She developed a brain hemorrhage and died. And when I
wow.
got that phone call, I felt like I had been punched in the gut. I felt like something so wrong had just happened because our system failed us. I followed the best evidence based guidelines. I took care of her the best conventionally and integratively that I knew how, and she had a fatal stroke. So something in my system was missing. Something in my system of evaluating patients was lacking that I didn't know. So I spent 3 years going to every conference that I could think of to try to understand cardiometabolic health and what might I have missed. And when I learned the secret, I called her daughter and I said, Cheryl, I think I know what happened to your mother. Is it possible that in the weeks leading up to her stroke, that your mother had a dental problem? She goes, well, yeah, why do you ask? I said, because I have now learned that mouth bacteria can get in the
Mm-hmm.
bloodstream and cause plaque rupture, and they can be the trigger for a stroke. She goes, well, she had a toothache. She was
Wow.
put on antibiotics. She was supposed to have that tooth extracted the next week, but she never made it to that appointment. So,
So that acute inflammation is a
so
powerful trigger.
almost certainly, and we have no way to know, but almost certainly that acute inflammation of that dental infection was the straw on the camel's back. Now, in retrospect, I never tested her for sleep apnea. I never tested
Right.
her for impaired glucose tolerance. So there were some other things that I may have missed along the way.
Yeah,
But
some other milestones. I have to tell you that I have a similar story, but it was much more acute because I used to work in a hospital that served a very large inner city population, and there were a lot of young patients in our hospital sort of area that came for care, and they had absolutely uncontrolled traditional risk factors, including hypertension. And so we, of course, did typical cardiac workup to see where patients are at. Do they have any thickening of their heart muscle? Do they have any calcification in their carotid arteries, any plaquing, what the heart situation is overall like? And so there was this one young man, in his mid 30s, a black man who didn't have necessarily a very bad blood pressure. He was what we would consider by contemporary guidelines, at least in the United States, stage 1. right? That's what we saw. In Europe, he may actually technically, and we'll talk about it a little bit later, may actually not even be called a hypertensive. But this is all we've known about him.
Right.
And so he was there for a stress test. And, part of the situation that is involved with the stress testing, of course, is that we watch very carefully for a person as they exercise, the blood pressure comes up, the heart rate comes up, and these are all normal, expected responses that our cardiovascular system is doing. As a matter of fact, if blood pressure doesn't come up or if it falls, this is a huge, huge, huge red flag. So as he was kind of at the end of his exercise, he came off the treadmill and everything looked fine. And somehow in that moment, he must have been so inflamed coming into it. And, being in a city hospital, sort of that inner city community, really didn't have the latitude to pile on a ton of testing, to figure out his inflammation. But, there were some inflammatory markers. There was some mild renal insufficiency. So we could see that some organs have begun to suffer from the hypertension effects, right? Even though his initial level may not have been as terrible. But in that moment, when he came off the treadmill, his blood pressure actually literally skyrocketed. And he had what we would call a hypertensive emergency because he immediately went into heart failure. We had to resuscitate him. He survived. There was no neurological deficit, but just seeing it unfold in front of us, and realizing that this could have happened to this patient at home, this could have happened to this patient on the street, this could have happened to this patient when he was picking up his kids from school, right? It could have happened in any situation. So I think what we don't appreciate, or maybe as practitioners and perhaps patients as well, is that hypertension till this day still remains a silent killer. This is what people call it. Do you believe it in this? Like, is that how you see it? That it's still a silent killer and people are, great many people are unaware that this is exactly what's going on with them.
If you get symptoms from your high blood pressure, if you get a headache, if you get fatigued, if you get blurry vision, count yourself lucky.
Yeah.
Because for the vast majority of people, the only way that they know that they have hypertension is to have their blood pressure measured at a practitioner's office. And that symptom of elevated blood pressure is often the first red light on the dashboard of your metabolic health that you have a warning problem, that something is amiss in your system. And usually that's a marker of oxidative stress or internal rusting or inflammation in your blood
Yep.
vessels. And
or,
so,
or all of the above. And
right,
it's interesting that you bring it up because I sort of see sometimes, we as adults, we are good at playing games, right? And one of the games we're good at playing is that we are very good at self deceit in many ways, right? So, very often I see a patient, and just recently a patient contacted us and said, he said, I'm upset about that my current doctor is not ordering a 24-hour home ambulatory blood pressure monitor because, I had high blood pressure in the doctor's office and my home blood pressure is perfect. And I think this is all just a white coat effect, or white coat. We don't know if he has white coat hypertension, but he is alluding to white coat effect. So how often, let's say, like reflecting on your practice, you have a very busy clinical practice. How often do we see blood pressure, which is technically falling into the elevated range, right, by the current guidelines? How often would you say you see it in your office? Is, let's say, if you were to kind of reflect on the whole group of patients that come and see you?
probably 3/4 of my patients,
Yeah.
right? I would say. And remember, I have a functional medicine practice. I
Right.
have a practice where patients value their health. They're willing to spend their hard-earned dollars on their health in ways that aren't covered by their insurance. And they are highly motivated to make changes for a healthier lifestyle. And still, 3/4 or so of my patients have elevated blood pressure. Now, do they all get blood pressure medication? No, but they all get a blood pressure plan, right?
Sure.
And so
Sure.
that means let's start digging. Let's start looking. Do you have undiagnosed sleep apnea? Do you have undiagnosed insulin resistance? Do you have undiagnosed dental infection. And so with Dee's story, once I was convinced that she had an oral systemic problem that was likely the triggering event for her stroke, I buckled down. And a girlfriend of mine is a dental hygienist, and she called me and said, I'm looking for a functional medicine practitioner to help me write a book about
Mm-hmm.
oral systemic health. Will you share with me? And I said, yes. So we wrote this book together about oral systemic
Oh.
connections, and we pitched it to 85 different publishers, and nobody wanted it.
Oh no.
And
Okay.
so I went back to the drawing board, and this is in 2019, right before pandemic. And at
Mm-hmm.
that time, I said, all right, nobody wants to know about oral systemic health. Nobody cares about it. Nobody knows they need to know about it. So what do they want to know about? So I went to Google and I searched what were the top 10 best-selling health books for the last 10 years, and what were on Amazon. On Amazon, what were the top selling books, and on Google, what
Mm-hmm.
were the top
Mm-hmm.
health searches. And 10 years in a row, high blood pressure came into the top searches. And I said, aha, that's what I'm going to do. I'm
Well,
going to write a Trojan horse.
yeah,
I'm going to write a
there
book
it
about
is.
blood
There it
pressure.
is. But, and I'm not surprised because you said in your practice where patients are very much attuned, right, to health and wellness and are seeking health and wellness or deep understanding of the root causes, you're seeing elevated blood pressure about 75% of the time. I honestly, if I do see normal blood pressure, it may be like 10% of the time that I actually see normal blood pressure, and maybe 90% of the time my patients fall into elevated or hypertensive group. And it's actually not surprising because if you think about it, the overall sort of crude prevalence of elevated blood pressure in the United States, at least based on what the guidelines tell us and the reporting tells us, let's say 130 over 80 or greater, or people are taking medication, that actually is almost 50%. It's slightly higher for men versus women, but across all age group, it's 50%. So that's 1 and 2. And once people become older, this actually increases. So for example, for people in their mid 50s to mid 60s, sort of right before Medicare age, we're looking anywhere from 60 to 70% in men and women. So it's like you said, 2/3 of them are there with this elevated blood pressure. And so statistically, we are seeing quite significant uptick. So what do you think is driving this? And, based on your research, I'm sure you did a lot of research for the book. Is the situation that we're seeing in the US sort of similar to other, let's say, developed nations, right? European nations, how do we compare?
Yeah. I mean, I think that we are a bit worse in America, but you also look at our body mass index and it's worse in America. And why is that? I don't think we have the exact answer, but I have two pretty good theories that are fairly well based in science. Theory number one is that we as a society are obese, and we are more obese than ever before because we are more toxic from environmental toxins than ever before. Pesticides, herbicides, petrochemicals, artificial flavors, artificial colors, flame retardants, jet fuel. All these things are microplastics. They're all in our environment and in our food and in our drink. And our bodies protect us against these toxicants by burying them in fat. So we get
Mm-hmm.
this nice layer of fluffy fat to help protect us against
to
our
to
environmental
to
toxins.
help to bury our toxins so that we can get rid of them.
Right. So as a result of that, we carry more weight, and that fat is a metabolic organ that triggers oxidative stress and inflammation, and that makes the vascular resistance goes up and drives our blood pressure. So theory number one is obesity as a consequence of toxicants. And theory number two is that I think we have mitochondrial dysregulation from so much electromagnetic smog. With the rollout of 5G, we're exposed to something like 1 quintillion times more electromagnetic energy than we were 20 years ago. And I think that this helps dysregulate all of our hormonal pathways, our metabolic pathways, our immune system. And I
Mm-hmm.
think we are just more likely to have irritated, inflamed blood vessel walls as a result.
Mm-hmm.
So
So
I think
it's
that that's
interesting because I have a theory number three, I guess,
yes,
to add to this. And the theory number three is actually that we are riding a cortisol curve, which is out of control, right? And so we actually have chronic and ongoing and repetitive stress that is not resolving, not mitigating, because people have obviously jobs and family commitments and financial stress and stress
right,
related to world events. And so we never are in a situation where, except for few rare instances, where we're truly relaxed. And so our sympathetic and parasympathetic nervous systems, they are out of balance. And so we are constantly in that state of sympathetic overdrive.
yeah,
And what's interesting, this has been recognized as a reason for some patients who manifest resistant hypertension, right? Resistant hypertension is when a person remains to be hypertensive. They've been treated with at least three medications. One of them is a diuretic, and we still don't have blood pressure under control.
yeah,
And our more conventional colleagues, they refer to it as hypercortisolism, meaning high cortisol levels. And usually they attribute it to a source, let's say anatomical source in your adrenals, that may be something called adrenal adenoma, that may be secreting extra hormones more than you need. But I think in most of us, these fluctuating levels of blood pressure, especially labile hypertension or borderline hypertension, there is not necessarily an adrenal adenoma that pumps out too much cortisol, but we're so stressed that
right,
we still are pumping out too much cortisol. And,
right.
now
I'm
blood pressure does
and
what it's supposed to do.
and even independent of cortisol, I think it's still a hypersympathetic response, right? So
Exactly.
I measure a lot of 24-hour cortisols, and I don't see an epidemic of hypercortisolemia. What I do see, though, is an epidemic of high blood sugar, high blood pressure, and high cholesterol. So let's go back to physiology, right? If I'm about to be eaten by a grizzly bear, the following things are
Let's
going to
hope not.
happen. The following things happen to my body instantaneously. I don't get a choice, right? My pupils dilate, my armpits sweat, my hair stands on end, my heart beats really fast, my blood pressure goes up, my blood sugar goes up, my blood cortisol, my blood cholesterol, everything goes up so that I have all the power that I need to fight that grizzly bear to the death or run away and get away from him, right? Fight or flight. Beautiful physiologic response. The problem is if I go to the doctor with high blood pressure and high sugar and high cholesterol, I leave with three medications. They
That's
never
right.
ask me what's stressing me out because no longer is there a grizzly bear in society, but we have this many emails and this much time and this many bills and this much money and these many commitments and this much time to do them in. And we're constantly driven with this high dopamine of our cell phones and our computers and our inboxes, and we never rest. We
That's
never
right.
take the
That's
time to
yeah,
unplug and reboot our
right.
parasympathetic nervous system.
We are
So
in a constant fight or flight
like
response.
a
It
broken record, we stay
constant fight and flight response. And I think I agree with you entirely that it's driving pretty much all of our chronic diseases. Like what's interesting is that I have some patients, for example, once they retire, right, and they stop working, all of a sudden they get so much better blood pressure control that they really didn't have before. And that's exactly the parallel. So another, I think, corollary of this, what feeds into this fight or flight response and the lack of stress resiliency is also ongoing sleep deprivation, right? Exposure to
yes,
blue screens. And they are sort of like two evil twins, right? Traveling with each other, stress and sleep deprivation. So let's maybe walk through a patient scenario so that our listeners could understand, how you and I think about it and, what's in the doctor's heads when we actually see someone, maybe someone like you who has had blood pressure issues or thinks you're having blood pressure issues, right? Let's suppose we are seeing a 60-year-old man. It could be a woman, but I'm going to say 60-year-old man. And he comes to see you, Dr. Ellie, for the first time, and or your staff is about to check their blood pressure. I mean, you go over it in a book. What would be a good way to actually check blood pressure for this person in a way which is accurate and makes sense.
Right. Well, I'll tell you what we did wrong, because we did it wrong
Okay.
for a lot of years, and most medical offices, I think, do it wrong. So John is sitting in the exam room or in the waiting room, right? And the medical assistant calls him to the back. Hey, John, how you doing? It's time. You're going to see Dr. Campbell. She wants vital signs on every patient. She says vital signs are vital. So come on with me. How's the kids doing? How was your commute in today? How was your work? Is everything going great? Have a seat right here. Let me check your blood pressure. I'm going to put the blood pressure cuff on. Oh, so you're sitting on the exam table. Oh gosh, your feet don't even touch the floor. Well, that's okay. Just, we're going to put this thing on your arm. We're going to check your blood pressure. And oh my goodness, it's 160 over 90. That's pretty high. Let you sit here just a couple minutes, see if we can recheck it. Wait 2 minutes, check again. Oh, it's still 160 over 80. All right, I'm going to write that down. She'll be in here in a minute and come see you.
And that is happening. So let me just stop you here. That is happening hundreds of times per day in thousands of offices. Just so it's not an exception, it's actually the rule. What
Right.
should be the rule?
So the first rule is that there should be an opportunity for this man to empty his bladder before he's even brought to the back, because having a full bladder can raise your blood pressure 10 or 15 millimeters of mercury. Interesting that you chose as your example a man of 60 years old. The
That's
probability that he
deliberate.
has the probability that he has a slight prostate problem, an enlargement of his prostate, and he's not able to ever fully empty his bladder could be the reason why he has hypertension.
Right.
And if he gets his prostate treated, and whether that's surgically or medically or a procedure to staple his prostate open so that his urethra is open and his bladder can fully empty, he might be cured of hypertension just by treating his enlarged
Or
prostate.
at least seeing it improved, right?
Right.
Depending on the level of orientation.
Yeah,
So
10 to 15 millimeters sometimes. That can be the
yes,
difference
I,
between normal and not.
correct.
So
So
the
you have
first
them
thing,
empty their bladder,
empty their
right?
bladder. Next, shh, quiet, no chit chat. If you have conversation going with your medical assistants or your front office staff, you can raise your blood pressure 10 or 15 points. So we have our patients seated quietly with no chit chat. When you put the blood pressure cuff on, it has to be the proper size.
That's
Most
right.
offices, there's very specific ways, if you're a medical professional, to measure in millimeters of mercury the width of the arm and which cuff size it matters. But I'll tell you a quick thing is most offices use an adult standard blood pressure cuff.
That's right.
Most modern adults have this that is too large for that normal size cuff. We need a long cuff. If you try to graduate to the next larger size cuff, which is a thigh cuff, and you're only 5 feet tall like I am, that cuff is too long for my arm and you'll get a false reading. So you have to have the proper size cuff. So the most common used cuff in my office is the adult long blood pressure cuff.
Hmm.
So once we get the right size cuff, it has to be on a bare arm, not over a sweater, not over a coat, not over even a t-shirt. It should be on a bare arm, because over clothing, up to 40 millimeters of extra blood pressure reading
That's
can
right.
possibly be obtained.
And it's important also to note, because we're going to go into the discussion of home blood pressure monitoring as well, that sometimes patients get sort of talked into, or maybe they do some internet sleuthing and they say, I'm going to be fancy. I'm going to get myself a wrist blood pressure monitor. Right. So what's the problem with the wrist blood pressure monitor?
Yeah, well, A, they're not quite as accurate. B, they very likely are not held in the proper position. They're supposed to be at heart level, and it's so easy to put your arm down and not get the right reading. Your arm has to be supported when you're measuring your blood pressure. So even if you're wearing a wrist cuff, if you're not supporting your elbow and supporting your arm, you're not going to get an accurate reading. An
That's very
unsupported
true.
arm can raise your blood pressure 10 millimeters.
Less
So
accuracy and certainly less
additional
ability to
pressure.
position properly at the heart level with proper support so that the arm is relaxed. So let's say you do all of this, you gave them some
There's
space,
another, there's
some
another
quiet
one.
time.
There's another really important one, because I'm vertically impaired. You are too, Dr. Druz. We are,
Okay.
we are vertically challenged, right? So we need to be seated in a chair with our bottom to the bottom, our back supported on the back of the chair, and our feet on the floor. Most chairs in most offices, if I sit with my back supported, my feet won't touch the floor. And if I have unsupported feet, 5 to 10 millimeters of mercury extra added to my blood pressure that shouldn't be there.
So there has to be a special chair and a special room, right? I usually, what I do is that I ask the patient to empty their bladder and bowels if they have to. And I take them into the exam room. The exam room usually has blinds, and I actually make them lay down so that they are not, trying to wiggle or position themselves in a chair or anything along those lines. And I give them maybe 2 to 5 minutes just to relax. No conversation, no phone, just sort of just laying there, relaxing, because chances are they ran and, they drove to see me, and we need a little bit of that downtime, right? That
Right.
relaxation time.
Yeah, absolutely. And so, I never in my life have been offered a step stool to rest my feet to get a proper blood pressure, which means probably in my entire life, I've never had a truly accurate blood pressure
Blood
check
pressure measurement.
in a
Exactly.
doctor's office if you follow these new 2017 guidelines from the American Heart Association and the CDC.
Hi, everyone. It's Dr. Regina here. I know there are contradictory opinions about nutrition for heart health and longevity. Discussion often gets heated and confusing. There are those who push for low fat, low cholesterol, and then there are fans of a ketogenic diet. There are many anti meat voices as well, suggesting vegan or vegetarian style of eating. With all the chatter out there on what and how to eat, my team and I decided to create a tool for patients, medical professionals to clear the clutter. It is called Holistic Heart University, and it provides on demand courses, nutrition and lifestyle resources, information on supplements to make it easier to understand how to make healthy choices for your heart. I'm especially proud of our open office hours for program patients and the Q&A feature where you get to ask your individual questions and put us in the hot seat. Head out to the show notes for the link and use my special promo code to get a huge 20% off on our annual health and wellness subscription. The code is owner20, and I'll see you in the office hours. So let's say this gentleman, you follow the steps, and I can tell you have another little blood pressure hack. So to avoid a situation where a patient may still be a bit, I guess, excited or nervous, or hadn't sort of settled into their routine, I actually do my vital signs at the end of my exam, not at the beginning. I think the timing is also important because you don't want that sort of priming effect of a patient focusing on their blood pressure number right at the very beginning of examination, because that's actually going to produce additional anxiety. It's better to hold off till the end. I find that helps sometimes with some patients who are anxious. But you mentioning the ACC and the AHA guidelines, and of course very recently in 2024 we had European Society of Cardiology guidelines. So let's say this man, he is in your office, you followed all these steps, and now you're getting his blood pressure, and it's 140/90. What is this a concern?
Yeah. So according to the United States guidelines, that man's in stage 2 hypertension. And
That's right.
we have, it's interesting because a normal blood pressure reading is now defined as 119 and 79 or less. But
That's
a
right.
hypertension, 130 or 80 or
Hmm.
higher. So
That's the
that's a
American
90
guidelines.
or
So 130 and or 80.
right.
And so in Europe,
140 90 is now clearly stage 2 hypertension. So that's a problem. Now, could it be a white coat phenomenon? This is the first time I've ever met this gentleman. I don't know what traffic was like coming up 400 driving over here. So it could be a stress phenomenon. It could be nothing more than a appropriate response to a physiologic stressor.
so how
Or
do you,
it could be
so let's
hypertension.
So a true hypertension. So how do you so I gave 140 over 90 deliberately because this is actually where American and European guidelines agree,
Different.
right? So once you're at 140 over 90, that's hypertension. It's just in the US, the guidelines are a little bit older. They were put out in 2018 or so. And that particular level is called stage 2 hypertension. And so in the US, to be considered normal, the upper number, the systolic blood pressure, has to be less than 120, and the diastolic blood pressure has to be less than 80. So, exactly as Dr. Ellie says, 119 over 79 will get you a pass,
Yeah.
but 120 over 80 will not really get you a pass because at that point you will be considered to have actually stage 1 hypertension because your lower number or bottom number, as patients like to call it, is 80. Because to be considered elevated by the American guidelines, you have to still be less than 80 in your diastolic blood pressure, or your second number, right? So there are very, very strict guidelines. The European guidelines are a little bit less strict because they allow not non-elevated blood pressure is still pretty rigorous. They do allow 120 over 70, so less than 120 over 70 is a goal. But if a person goes all the way up to 139 over 89, they don't call it hypertension, they call it elevated blood pressure. So there is sort of a discrepancy in that middle zone. So obviously depending on where the measurements are. So how do you
And the
evaluate?
Europeans allow you like some clinical discretion too, right? Like if
Yes.
the patient's already had a heart attack, then you need to be more strict with managing their blood
Of
pressure to
course. So
reduce
the
their
so
chance
the
of that
cardiac risk,
recurring.
and also in the European guidelines, there is some consideration, let's say, for the age of the individual. But in general, hypertension being probably the number one most impactful cardiovascular risk factor from the point of view of heart attacks and strokes, the guidelines do always put it in context, right? And that's another super important point because I see patients getting stuck on the number itself, not realizing that the number may or may not be bad, or maybe the number even is good, but it may not be good enough for you because the overall context of cardiovascular risk is different from person to person. There are people who have fairly high risk of cardiac events in the next 10 years. And of course, younger people have a very high risk of events over a lifetime risk, right? But the short term risk, 10-year risk, may be low. But there are people who have a much higher risk estimate for the next 10 years. And so for those people, even stage 1 hypertension or elevated blood pressure is a risk factor, even though it's not, blood pressure off the charts. So this is where I think this often gets missed because patients are so fixated on the number and what the numbers mean. And it's a classic situation of, missing the forest for the trees.
Yeah. I also think that often in elderly patients, doctors give them a pass when they shouldn't, because we know that systemic vascular resistance increases as we age. Our blood vessels
Yeah.
get stiffer, our blood pressure goes up, but that also means our risk goes up. And so just because it's common doesn't mean it's healthy. And we often, when I was in medical school, 160 over 90 in a senior was perfectly acceptable blood pressure. We didn't treat it. We didn't
Yes.
talk about it. We let it
Yeah.
slide. It was common and normal. And we now know that those seniors suffered as a result of our not treating them. They developed heart attacks, strokes, kidney failure, blindness, all the complications of hypertension because we felt like because it was common, it was normal. And we were fearful that if I try to treat this patient, their blood pressure is going to get too low. They're going to get weak and dizzy. They're going to fall down. And I know how bad falls are for senior citizens. And it turns out that that was a misguided thought on our clinical part.
And I remember that because when I trained, I sort of got the tail end of this, right? So, and that was at the time, I do remember even some cardiologists that I looked up to, some of our mentors said that you should never take a blood pressure to less than 140/90 for an 80-year-old because, they're going to fall and it's sort of going to be all you're doing. But just as you're saying, this actually happens the group of patients where the strokes, the heart attacks, and also heart failure are actually happening because of the blood pressure. It was not necessarily a very useful strategy, and I think data doesn't really substantiate that was something that we were supposed to do. It actually shows us quite the opposite. So let's talk about white coat effect. This patient, he is meeting you for the first time. Now he's coming in. He is 140/90. What is the white coat effect, and how do you maybe in the office setting or in any other way try to figure out if a patient has it or doesn't
Right.
have it?
So the white coat effect is a burst of adrenaline, sympathetic. They see this white coat and they're fearful. And
Or they
so,
see you even without a white coat and they're
right,
fearful, right?
right. And so their blood pressure jumps up, sometimes a little, 5 or 10 points, sometimes a lot, 50 points. Some people are very prone to this startle effect from their blood pressure. So we need to try to distinguish that from true hypertension. Or sometimes if we have a suspicion, the opposite of this is called masked hypertension. And that's people who are so good at getting in their zen before they come to see the doctor that their blood pressure is perfectly normal in the office.
Mm-hmm.
But once they get home in the kitchen and start making dinner or fussing with their kids, their blood pressure is off the chart. So we need home data, just like I would never in my office make a diagnostic care plan for a patient on a single blood sugar reading. Oh, you're a diabetic. Your blood sugar is 227. You need to take 7 insulin units 3 times a day for the next 7 days. Come back and see me in a month. From one reading, I would never do that. Nor should I make a blood pressure care plan for a patient based on a single office reading. So we need
That's
more
right.
data.
And
And
so the great part, I think, of both the American guidelines and most recently the European guidelines is a very strong endorsement of home blood pressure monitoring on par with 24-hour ambulatory blood pressure monitors, because I sort of grew up in the era where 24-hour ambulatory blood pressure monitors were very popular. But I can tell you that a patient may have great 24 hours or terrible 24 hours. These machines are noisy, they disrupt people's sleep, so it's not really very comfortable, and it certainly
So
doesn't.
let's explain that, an ambulatory blood pressure monitor. So a home blood pressure monitor, everybody kind of understands that, right? They go to CVS or Walmart, they buy an Omicron unit, they take it home.
Or exactly.
They're not going to buy the
No,
wristwatch
they're not,
because
because we told
understand
them
they're going to
not
buy the
to. They're going
arm
to buy
one,
the standard
and
one.
they're going to make sure
Yes.
that the cuff is the proper size, right? And they're going to
Yes,
follow the 7 blood
exactly.
pressure
And they're going
guidelines.
to place their feet on the floor. They're going to empty their bowel and bladder. They're not going to speak. They're not going to drink coffee or alcohol. And they're going to just focus their thoughts on being relaxed. So they've
Right.
done
Because
all of
we
that.
want to standardize these readings, right? So we want everybody on the same playing field so that we can measure them, right? We don't have some people run a 100-yard dash on an uphill and some people run on a downhill. Everybody runs the same so that we know who's the best. Well, this is what we're trying to do, is set the playing field so we know this is how we're going to evaluate your blood pressure. So you've got your cuff at home and you're going to check it a couple times a day, a couple times a week. You and your doctor can decide how often you need to do that. But that's home blood pressure monitoring.
So
That's
let's stop you right there, because so that people who are listening to us can actually understand, because there's such a wide variety of these home blood pressure monitors. So first of all, you can find an approved list on one of the government websites. They actually have Center for Disease Control has a very, very long list that you can look at. But most of the common ones that you see at pharmacies or internet retailers, Omron and various other ones, they are actually validated devices. And typically, if you are using a home blood pressure monitor, and I do believe that every adult needs a home blood pressure monitor, my preferred company is Wittings, but that's simply because of the ease of use and the fact that we're able to follow it on our back end through the practice dashboard. We can actually see the blood pressure responses. I like the fact that some of these automated Bluetooth blood pressure cuffs allow you to take 3 readings at a time, because just like Ellie says, we're not going to jump based on a single reading unless a person has obvious clinical symptoms, right? They're having a heart attack, they're having a stroke, or hypertensive
That's different.
emergency, right? But if they are completely fine and we're getting this high reading, we'd like to get at least 3 and take an average. It's called mean, right? Your mean blood pressure measurement. So it requires a little bit of time, because you're sitting at home, you kind of, position yourself as your back supported. You need to take those 3 measurements. Either you're writing them down, or the machine, sums them up for you and it goes into your mobile app. And this is something that I have my patients do morning and night in approximately the same time frame, exactly as you said, right? Let's standardize the measurement in exact same situation for at least a couple of weeks, so that I can understand what's happening, what's their vascular system is actually seeing. Now, how is that different from 24-hour ambulatory blood pressure
Yeah,
monitor?
so an ambulatory blood pressure reading is usually a 24-hour test. It's usually something you either borrow or rent from your provider's office. So it's not
Hmm.
something that you keep at home. It's a medical device that's sent home with you. You wear it continuously for 24 hours. And every
Yeah.
few minutes, it's pumping up and giving you a reading. Some people find it very annoying to try to
I
work.
find it super annoying, and I don't use it with my patients
Can
much
hardly
because
work on your keyboard, can hardly go to sleep, can hardly eat your meal as soon
it will
as,
wake you up. Basically, at night you won't get any sleep, so blood
but
pressure will be up.
it's considered a medical standard.
Mhm.
So many practices use these still preferentially. I don't use them much. I will refer once in a while to my cardiologist, who has a bookshelf full of them, and will give them out to their patients. But I find that I can get pretty good data at home. And although I certainly love the idea of those standardized, 6 a.m. and 6 p.m., let's do it at the same time, I also say that blood pressures are kind of like son-in-laws, right? You want to see them on their best behavior, and
And
you
their
want to know
worst
what they're
behavior.
like if they're
Oh, I love
worse,
that.
right?
I
So
am with you. I don't use the ambulatory blood pressure monitors, because I think they could give a patient a reading which is not really replicable in real life, right? Because they're a disruptor in and of itself, and they sort of don't give a patient a longitudinal opportunity to follow over time. Because we all know that we as people may go through some rough periods, and maybe that's
sure.
24 hours happens to be not the best
Or an
period for you,
unusually quiet one,
or
right?
usually quiet one, right? You're on vacation, you're relaxed, you're happy. So, so it's really sort of a very artificial scenario where the home blood pressure monitors are considered to be on par with these ambulatory blood pressure monitors. And what's good about it is that there is sort of levels, corresponding values of blood pressure that we have. So let's say our patient here, you opted against this 24-hour ambulatory blood pressure monitor. You advise them to follow the home blood pressure monitoring routine, and they come back, and on the home blood pressure monitoring routine, the patient says, "Hey doc, I'm really happy. My home blood pressure monitor, like the app, spit out all these little numbers, right? And so I am at 130 over 80 on my home blood pressure monitor, and your office blood pressure was 140 over 90. Is it hypertension or not?"
Yeah, I would say, and the answer is yes, still, but you dropped from stage 2 to stage 1.
Correct. That's
So
right.
it's still hypertensive. And the good news is we may be able to find some underlying root causes that won't require lifelong medication.
That's
At
right.
140 over 90, if all your readings at home were 140 over 90 or higher all the time, we're going to have a hard time treating that without medication. But at
And
130 over 80, I think you got a pretty good chance.
that's right. And so this, and the same, actually, sort of the reverse of it works for masked hypertension. So, so for us to tell you as a patient that your blood pressure is normal, this is called normotensive. There shouldn't be a crossover into any hypertension threshold, whether it's in the clinic setting or the home setting. Both of them should check out and be normal.
Right.
However, if both numbers are were in the hypertension range. And this was exactly the situation here, because patient was 140/90 in a doctor's office, and 130/80 was their average number after doing a bunch of home blood pressure measures. That's still hypertension, and this is called sustained hypertension, right? And so the white coat hypertension is a different situation where they are hypertensive in a doctor's office, or let's say a clinic setting, and maybe there's a reason for it. But at home, the average numbers from that home blood pressure monitor or any other device are actually in a normal range. And to be in a normal range by the American guidelines, when you're using the home blood pressure monitoring, you have to be less than 130/80, right? It cannot, the average cannot cross that. So this is super important. So
I do want to say one other thing too about wearables, that we are starting to get to the point where we will be able to use our Oura rings or a patch that we wear on our chest, or some other device that's not a cuff to measure blood pressures, or a finger that you put on the end of your iPhone and it'll measure your blood pressure. We're not
yeah.
there. Do not
Actually,
trust those
at the
numbers.
holistic heart centers, we're almost there,
We're
because
almost there.
in a very short period of time, we will actually have an online tool where we can actually measure your blood pressure by you just looking into it. This is how interesting it will be, but obviously
We're getting there.
it
And you know
requires
how
physician
AI
validation,
technology is so quickly developing.
developing very fast.
Very soon. And we're going to have dashboards where your provider will be able to monitor your blood sugar and your blood pressure and your blood cholesterol and your cortisol level and your.
So we do this routinely. So, we kind of have a whole dashboard that gives us the body composition, the blood pressure, the stress, the recovery, and all the other biometric parameters. But that's a lot of work. But I have to tell you that it's been a game changer for sure, because addressing all of these root causes that you mentioned, impaired glucose tolerance, tissue level insulin resistance, inflammation, poor body composition, right? We haven't even talked about that, how when we start to get older, we become mature adults or older adults, there is a very notable shift in the body composition that affects our metabolism and actually affects the level of inflammation in the cardiovascular system, making us in many ways hypertensive. So there is so many connections. So let's say we're going to go back to this particular patient. And so we now found out that he is unfortunately hypertensive, right? It is a sustained hypertension. It's just in the office setting, he showed a white coat effect because it was a little bit higher, but at home, he still was in the hypertensive range, right? So this is what we call white coat hypertension, or in his case, it's really not, because blood pressure at home is also elevated. So it's just hypertension with the white coat effect. What are you, as an integrative functional medicine doctor, what are the next, let's say, top 3 or top 5 things that you want this patient to do, either with the medication or even before you start medications? What are you actually, how you make this decision, what this patient should be doing next?
Right. Well, it's so multifactorial. We do many things at one time, but I would say that, if we're about to do CPR on somebody, we do ABCs: airway, breathing, circulation, right? Airway is the first and most important thing. And so for a hypertension patient, I need an airway assessment. I need to know that their airway is wide open at night and that they're sleeping deeply and soundly without disturbance. If they're snoring, if they have a large neck, or even if they don't, because 55% of sleep apnea patients do not fit what we would think of as a
Right, the
sleep
standard
apnea body
criteria.
type. So that's one of the next things I'm going to do is I'm going to send this patient home with a home sleep test to screen for sleep apnea, because it's so, so, so common, so overlooked, and so easily treated. And I have at least 6 treatments for sleep apnea that are not CPAP masks. So once patients understand that, I might send them for oral myofunctional therapy, or they might have an ENT evaluate their nasal passages, or maybe they're going to wear a bite guard at night, or tape their lips closed, or wear a nasal splint, or just put a backpack baffle between their shoulder blades so they can't lie on their back, because that's the only time they have sleep apnea is when they're on their supine position. So I have all these different ways to treat sleep apnea that are not requiring a CPAP mask, and that increases the probability that the patient's going to accept the test when I offer it. So airway would be the number one thing that I would do. The next thing I would do is take a look at their basic blood work, and I would look to see, do I have markers of oxidative stress and inflammation? Do I have markers of vitamin deficiency, insufficiency, or anything that needs to be addressed? Vitamin D deficiency, for example, can cause hypertension.
Right.
Magnesium deficiency can cause hypertension. Potassium deficiency can cause hypertension. And then,
Vitamin D explains why in a nice and warm climate, when we're exposed to sunlight, our blood pressure goes lower,
right,
right? This is, the beach effect or effect of being on the
right.
beach. So
So, there's lots of things, and that all comes from one single blood draw. So I get all that data at one time to sort of sort through it. But in our experience, many people have been told before they see us that their blood pressure is high because they eat too much salt and they need to cut salt out of their diet.
and I always tell them it's not salt, it's sugar. So,
Right. And it's sometimes salt, but not always, very
almost
less
all
often than
very
you think.
rarely.
And that people who are salt sensitive are often not salt sensitive if they're magnesium and potassium replete. So
That's
we
right.
give them enough magnesium, we give them enough potassium, and now they can eat all the salt they want and it doesn't jack their blood pressure.
Hi, everyone. It's Dr. Regina here. Many of my colleagues and I are noticing patients coming to us with self ordered blood tests. When this trend started to gain momentum, I thought it would benefit many patients. After all, who doesn't want more access to health testing? However, I see that self ordered labs often lead to more confusion and frustration for our patients. Patients are coming in with a pile of labs, and sadly, they're not better off for it. This is why we at Holistic Heart Centers have launched Heartwell Toolkits, a curated collection of blood and genetic markers that one can get at home, focused on heart and brain health, gives you all the data you need to make informed and actionable health decisions. The toolkits can be ordered at our shop on holisticheartcenters.com. You can find the link in the show notes. Use the code TESTING10 to get 10% off and free shipping. So these are great strategies. I can tell you that what I look at very extensively is that every new patient with us gets a vascular scanning. So we certainly look at what's known as hypertension related and organ involvement, right? Because whether it's masked hypertension situation, that's actually would be a definition that blood pressure is normal, but we're seeing, for example, some thickening of the heart muscle, which is a telltale sign that your heart is seeing pressures which are higher than they supposed to be. If there is, for example, anything in the carotid, there is any carotid plaques or your carotid intima media thickness is more than what you need to be based on your age and gender, because there are certain specific norms and you might be exactly where your age and gender is supposed to be, or you could be significantly higher than that, and that's all measurable. And also, we scan the abdominal aorta to see for any early atherosclerotic disease. And so if there are these signs of what's known as hypertension related and organ damage, in addition to surmising that you could have it, for example, from blood work, if we see any evidence of kidney dysfunction or any other, inflammatory markers being high, or your lipids are high, or there is pre-diabetes or just, predisposition to diabetes, we could get a lot of it from blood work. Autoimmune diseases, obviously, we didn't mention, but they are very impactful because they raise people's blood pressures all the time, occult infections. But the main decision making point is that if you have gone to a doctor's office and you are found to have elevated blood pressure, it is important for you to know, is it real? Or is this just a white coat effect? And one of the ways we figure out if it's real or not is everything that we've discussed. We take the blood work, we look at underlying factors, including sleep apnea testing, which I agree is absolutely underdiagnosed continuously, despite the availability of these testing. We'll look at the end organ damage. Is there a reason for us to think that your body is seeing the impact of blood pressure while you think you may not actually have hypertension? We'll look at the home blood pressure monitoring, and all of these pieces together then inform the treatment plan and the strategy. Yes, you could just, get a prescription from a doc, and sometimes it's absolutely necessary. I want to make sure that it comes through loud and clear. If you're in my office and your blood pressure is in 150s or 160s, you are leaving with a prescription. Right? We will sort all of this out. I promise. And so will Dr. Ellie. But you're not leaving out of the door. You're not leaving here without a prescription, because we've just seen way too many things. What happens with patients like these when they do leave without a prescription? So it is a multifactorial issue.
It is, and I mean, we'd be remiss if we didn't say somewhere along the way, a diet, alcohol, and exercise history is absolutely paramount. I mean, if you're living Cheetos and Mountain Dew, then we have an easy point that we can work on to correct, right? If that's the reason why you have high blood pressure.
Yes, and with alcohol, especially, that, there seems to be, and, I'm thinking of doing just like a separate episode on alcohol, because the patients are still somewhere there, I think, in the old cardiology literature is some sort of a statement that mild to moderate consumption of alcohol is good for the heart. This is absolutely nonsense, because the subsequent data did not, corroborate that. And we have evidence to the contrary with the most recent finding, and actually a warning by the Surgeon General, that alcohol is a toxin at any dose implicated in chronic diseases, including new onset of at least 6 cancers. So at least 6 cancers are related to alcohol. So this kind of concept that somehow you're doing good by your heart by drinking a glass of wine is please take it out of the window, just to please park it somewhere else. So, so I usually ask my patients to sort of, with hypertension, I ask them to do a dry January kind of fix. I ask them to limit or exclude caffeine as much as possible, because there's some caffeine association. Certainly exclude alcohol. We start almost right away with very basic intermittent fasting regimen, and we focus on limitation of sugar and some salt substitution to actually see what they can accomplish with that. Those are super easy to do. You don't need to spend a lot of money. You can literally do it in the span of a couple of hours. So those sort of like my very quick fixes. Last word from Dr. Ellie, your quick fixes, any pearls of wisdom that you want to leave our audience with? I just want to say that
heart attacks are optional and strokes are stoppable. Dialysis is not your destiny if you're willing to get the tests and do the work.
That's right. I cannot agree with this more. There is no magic bullet. The magic lives inside you. You just need to be able to unlock it. And, look for one of our earlier episodes called Rapid Response, where you can actually go a little bit deeper into how much weight you need to lose to achieve blood pressure control. And if you subscribe to the YouTube channel, you actually get a little blood pressure weight loss calculator, which is just a spreadsheet that you can plug your numbers into one by one, and it'll tell you exactly how much weight, especially fat specifically, you need to lose to hopefully get your blood pressure under control. Thank you so much, Ellie. It was a pleasure.
Yes.
Hi to all professionals listening to us today. If you're thinking of launching a cardiometabolic or integrative cardiology program in your practice, we can help. At the Holistic Heart Centers, we help docs in practice to expand into hybrid or concierge services. Head out to the show notes and click on the application link. Your intro call is entirely free. Ready to schedule a practice review? Use code DOC10 for 10% off our Practice Power Hour 16 minutes coaching session. The link is in the show notes. Thank you for tuning in to Own Your Heart Health with Dr. Regina Druz. This podcast is powered by Holistic Heart Centers. If you enjoyed the show, please rate and review us on your favorite podcast platform. To learn more about our services, visit holisticheartcenters.com and subscribe to our YouTube channel. The link is in the show notes. See you next week.